to today's virtual education event. I am Annie Yeager, the Marketing Product Lead for Everlift, and I will be your monitor for today's event. During the webinar, if you have any questions or comments, please submit them using the chat box at the bottom of your viewing screen. Questions will be addressed at the end of the presentation. It is my honor to introduce Harshit Khara, MD, FACG, FASGE. He is an interventional gastroenterologist based at Geisinger Medical Center in Danville, Pennsylvania, USA. Dr. Khara is an associate professor of medicine at the Geisinger Commonwealth School of Medicine. He serves as the director of endoscopy, director of endoscopic and translational research, and the associate director of the Advanced Therapeutic Endoscopy Fellowship Program at the Center for Advanced Therapeutic Endoscopy at Geisinger, participating in the training and mentoring of advanced endoscopy and general gastroenterology fellows. He is also the director of the National Pancreas Center at Geisinger. He is involved in multi-center clinical research projects and quality improvement projects. And his clinical research interests are in the field of interventional endoscopic ultrasound, ERCP, Barrett's esophagus, third space endoscopy, and bariatric interventional endoscopy. Dr. Khara is certified in gastroenterology by the American Board of Internal Medicine. He is a committee member for the American College of Gastroenterology, the American Society of Gastrointestinal Endoscopy, World Gastroenterology Organization, and the Pennsylvania Society of Gastroenterology, representing Geisinger at various national and international platforms. Dr. Khara earned his medical degree from Seth GS Medical College and KME Hospital in India. He moved to the United States to complete his internal medicine residency at Drexel University College of Medicine, St. Peter's University Hospital. He completed a fellowship in transplant hepatology at the University of Nebraska Medical Center and a fellowship in gastroenterology at Yale University School of Medicine, Norwalk Hospital. He completed another fellowship in advanced therapeutic endoscopy at Geisinger Medical Center. Welcome, Dr. Khara, and thank you so much for taking your time to join us today. It is my pleasure to pass the event over to you.
Well, thank you so much for that intro, Anna. And it is my pleasure, of course, to be sharing my experience with interventional endoscopy and the management of these large colon polyps. I'd like to thank GI Supply and the Endoscopy Now platform to be able to share my clinical experiences as well as research on this topic. So we'll get started. Again, we'll hold the questions till the end. This way we can go through it, but definitely feel free to jot your questions down, and I'll promise to get through them. This is the GI Supply Medical Education Program disclaimer. So the objectives of this evening's talk is to discuss the management of large colon polyps and what constitutes a difficult polyp, the endoscopic evaluation of these polyps, the do's and don'ts in the resection of these lesions, and as well as the options and tricks for a successful endoscopic resection, and techniques to minimize the recurrence of these lesions. So what does a difficult colon polyp mean? Well, traditionally, these used to be referred to surgery. Patients who had a large polyp or what we thought was an advanced polyp would end up with a colonic resection. However, the new paradigm has been colonoscopic resection. And we have various techniques, including EMR and ESD techniques. And this does entail the use of special devices and specialized snares, as well as customized electrocautery programs. And I think we can push the envelope now because we have better devices for defect closure. So even if there is an untoward event, then we're able to take care of it endoscopically with these closure as well as hemostatic devices. And the training is paramount to have the right support team along with you to be able to support these kind of cases. So what does constitute a difficult polyp? Well, there are multiple factors to this. It's the size of the polyp, the location where in the colon it lies, the morphology of the polyp, if it has a thick stalk or if it's a sessile polyp, the patient factors such as patient's body habitus, the adequate prep, redundant or loopy colons, underlying bleeding risks, as well as comorbidities. And there's endoscopist factors, which include experience with these kind of procedures, the training that is required and necessary, not only in the resection of these polyps, but also management of any complications. The ancillary support staff, the surgical expertise. Again, the buck doesn't stop with us. We need to make sure that we have the right support system in place in case if there is a perforation or a bleeding or any other untoward event, that we have surgical as well as interventional radiology support for these procedures and the ability to handle the complications. So a large polyp is usually anything greater than 2 centimeters or 20 millimeters. And a giant colon polyp is defined as anything greater than 3 centimeters. There is no upward limit to this. So, sky's the limit as to how big of a polyp we can remove, as long as it's within the realm of safety. Now, there are higher risks of malignancy as these polyps grow large, and it's not just in the lateral size, but also the depth of invasion. The success of endoscopic resections with these giant polyps is upwards of 90%. So we do save a significant number of cases from going to surgery. And of course, with the larger polyp sizes are the high risk of complications. So a polyp assessment, the endoscopic evaluation is very important because this has implications in regards to successful resection, recurrence, as well as complications. And that includes documenting the Paris classification, the morphology of the polyp, if it's a granular versus a non-granular polyp, and the pit patterns with various endoscopy techniques. So this is a chart that I follow. In fact, I have a printout of this in the endoscopy room, and we have a training program. So our fellows refer to this when documenting any kind of colonic polyps that we encounter, whether it be during a screening, surveillance, or a therapeutic colonoscopy. In regards to the morphology of the polyp, they are either granular or non-granular. And the risk of involvement with granular polyps is 3 to 7%, but if they're non-granular, that submucosal invasion risk goes significantly higher, especially with a multifocal invasion. So granular polyp will be laterally spreading, and the non-granular will be smooth, and we need to differentiate this when we evaluate the patient. The polyp surface patterns, the pit patterns of the polyp, which is done with chromoendoscopy, either with a classical dye-based chromoendoscopy, or if it is a digital chromoendoscopy. And we need to document the Kudo pattern, the Sano, or the Nice classifications. So inspect well before you resect. So before we make a decision to bring either continue in the same session or bring the patient back for an endoscopic resection, it is important to document these things. So how do we decide which pathway we're going to take? And that depends on the depth of invasion, and that is based on those endoscopic parameters that we just mentioned. So if the lesion is within the mucosa, so if it is a M1, M2, or M3 lesion, so if it involves the epithelium, lamina propria, or even the muscularis mucosa, it's fair game for endoscopic mucosal resection. And the idea behind that is we're able to lift these polyps off of the submucosa and able to get a complete resection. However, if it does involve the submucosa, then advanced techniques such as endoscopic submucosal dissection, or ESD, is usually ideal. And if these polyps have deeper invasions, if it involves the SM2, SM3, or if it invades the muscularis propria, then definitely these patients need to go to surgery. And that's not because of a lack of us being able to remove it, it's the risk of the local lymph node spread. So we may be fooling ourselves by removing this lesion endoscopically when the lesion may have already spread to the regional lymph nodes. So endoscopic resection techniques could be an EMR, which is an inject, lift, snare, and repeat, if it's an unblock or a piecemeal resection. And the pros, of course, are it's faster than ESD techniques. It's safer because we're laying superficial. It's less expensive in regards to accessories that are used as compared to ESD accessories. And it's relatively easier to perform in regards to advanced skill set. Of course, there is slightly higher risk of recurrence with an EMR, especially if the depth of invasion is greater than the submucosa. The ESD, on the other hand, the pros are an unblock resection, so we're able to get lateral as well as deep margins. In case of EMR, unless it's an unblock resection, if it's a piecemeal, it's hard for the surgical pathologist to tell us the involvement of the lateral margins because of the nature of the resection. But with ESD, we're able to get both lateral and deep margins, which gives us reassurance in regards to complete resection. Of course, it does take longer. There is a higher risk of perforation and complications. The devices, as you know, is much more expensive compared to EMR techniques, and it requires a higher skill set, and this is still limited to certain centers. One of the biggest roadblocks are also reimbursement issues, since we do not have specific codes for ESD, and our societies are definitely working towards getting us better coverage for these procedures, because we're spending more in regards to devices, and we're also spending more time and resources to be able to do ESD. So when you see this lesion, what do? Do you biopsy it? Do you do an endoscopic mucosal resection? Do you do an ESD, or you send the patient to surgery? And the answer is all of the above. It depends. It depends on the examination. It depends if this is the first time you're seeing the patient. Is the patient just coming in for a screening or a surveillance exam? And do we have the informed consent to take on more advanced endoscopic resection methods? Or are there patterns that tell us that we shouldn't even attempt this, that we should send this to surgery? So what are the do's and don'ts of removing a large polyp? Well, always look carefully with high definition white light and a digital chromoendoscopy, which could be a narrowband imaging, to check for signs of invasion. If there are already high risk features, removing this would be doing a disservice, as we would put the patient at harm's way without getting them a curative resection. Documentation, especially if we're referring this patient to another colleague, it's very important to give the appropriate landmarks and the visual aids so the referring doctor can then better prepare for these removals. Marking where the lesion is, and it's only if it's non-obvious. So I always tell my referring friends, if it's in the rectum or the cecum, I'll find it. Anything in between, if you feel I can see if it's a big lesion, I'll find it. No need to mark it. But if it's behind a difficult fold, if it's somewhere in between the colon where you think that it'll be difficult to find, definitely marking gives a better landmark for the subsequent endoscopist to find it. And even if it's a self-referral, when I do these procedures, I take on the endoscopic resection. Just because I found it now, there is no guarantee on a repeat exam I'll be able to find it again. So I would definitely mark it so I know where I need to land up in. However, the key step here is to mark away from the lesion. And the pitfalls of that I'll go over in some of the demonstrations I have in the subsequent slides. Bring the patient back for an EMR or ESD if the patient is willing and after an informed consent is obtained. So if the patient only gave you consent for a surveillance exam, doing a polypectomy is fine, but doing advanced endoscopic resections definitely is a higher risk, and the patient needs to be informed of that. Only begin the resection if we know we can finish what we started. So if you think, well, let me take a whack at it, it's only going to make it harder for ourselves or for the referring doctors to remove it later. So do not hot snare or biopsy if you don't plan to remove the whole lesion. It causes significant fibrosis. Do not tattoo underneath the polyp. Like I said, the tattoo needs to be away from the polyp at least 2 to 3 centimeters. And also when you inject, if the tattoo is spreading, make sure to stop and it doesn't run under the polyp. Never attempt a partial resection. If you don't think it's doable, bring the patient back. If the prep is not adequate, you think that it's going to be a problem to get a complete resection, bring the patient back with an advanced prep later. So here is an example of a lesion that was referred over. Now, this patient had a screening exam with another colleague, and as you can see, there is the tattoo placed right there, which is at least a fold away from where this lesion is. So this happened to be at the hepatic flexure. And as you can see, the important part in this is the examination of the lesion. So as you can already tell, that this polyp is an advanced lesion and definitely may not even be resectable. And I think what happened is the patient didn't follow up. The patient had a screening exam and was referred for an endoscopic resection, and the patient waited over 6 months. And in the interim, the lesion definitely progressed. So this was definitely a surprise because the initial pictures were not as advanced, which is why we brought the patient. So examination of this polyp under a white light and high narrowband imaging definitely tells us, is this something we should even attempt? And the important part in this was the tattoo, that it had to be away from the lesion, but it definitely brought our eyes to where we need to look at. So once we decide on resecting this, it's important to see what scope we're going to select. And the scope selection could be a slim colonoscope, an adult colonoscope, or a gastroscope. And I decide on the scope selection based on the location of the lesion. I usually prefer a pediatric or a slim colonoscope because of its ability and the agility to retroflex. So sometimes even if the polyp is at the hepatic flexure, it's easier to retroflex around the polyp to resect it from all sides or to inject it. However, if it's a patient with a high BMI or a very loopy colon, then you may need an adult colonoscope just to be able to get to the lesion. If the lesion is on the left side and it's within 40 centimeters, then I usually start with a gastroscope. Again, because of the length of the scope and the flexibility of the scope, it definitely gives us better options. But choose wisely. If there are certain lesions that certain devices you plan to use that are advanced endoscopic resection devices, it may not fit through the channel of a gastroscope. So check on the width and the thickness of the devices being used to see if it will fit the scope. A distal clear cap attachment is almost a necessity for advanced endoscopic resection. It serves multiple purposes. It helps with fold deflection to be able to find these lesions better. And it also helps in stabilizing the colon and the lesion to get underneath the lesion. The way I place my cap is there is a hole that goes in front of the cap, and I locate the cap hole at 3 o'clock on the clock face. The reason behind this is that this coincides with the location of the camera. So if the water pools in the cap, it can either suction through at the 7 o'clock location. However, if it pools on the right-hand side, then it falls out of the hole. And this is about the distance that I leave the cap out. It's just where the rim is visible around the scope. So you don't want it too far out, because otherwise you'll have a reflection of the light source, which will be detrimental in regards to endoscopic visualization. Now, I cannot stress the importance enough of a CO2 insufflation. If there is any advanced endoscopic resection planned, it has to be done with CO2 insufflation and not with air. And the reason is you don't know what you're going to run into. If there is a microperforation or if there is a perforation and there is free air, you just bought the patient surgery. However, with CO2, the patients are able to get away even with a colonic perforation, as this gets absorbed through the belly and is able to be sucked out easily, as I'll go over in some of the video demonstrations down. Device prep. It's important to make sure you know the Cautery settings on your electrosurgical generator. Before you start anything, make sure you have your customized programs as to what works for you. These are the settings that I use. So for an endoscopic mucosal resection where I'm going to use a snare, and this is on the Irby Vio 300D, I'll use the endocut Q mode with a 214 setting. However, if I'm doing a hot avulsion or a hot biopsy avulsion, I'll use the endocut I mode with a 313 setting. If I'm planning to do hemostasis, which could be with a hemostatic forceps, then I'll use the soft coag mode at the effect of 4 and a wattage of 80. So these are the settings that I have pre-programmed. Again, these could be tweaked, and you can always talk to your local representative to see what works for you to be programmed. Another point is for EMR, it's always the endocut or the yellow pedal. You don't want to do it with the blue pedal because it'll just cause significant charring without getting a clean resection. So for resection, it's always the yellow pedal or the endocut mode. In regards to the device prep, if it's EMR or ESD, you want to be able to raise the lesion. My preferred needle is a 25 gauge needle, and that's because if you have a thicker needle, you leave holes in the mucosa, and then for subsequent injections, you lose the injectate. So a 25 gauge needle is the best of both worlds. All the solutions, either pre-mixed or made with saline, are easily injectable through a 25 gauge needle, and it gives you a better lift for the initial as well as the subsequent injections. Snare, there are various sizes, various shapes, and various stiffness. I personally prefer a braided snare and a stiff snare to be able to better position the polyp and be able to grab it. However, be flexible. Just because one snare you start with doesn't mean you need to end with that, and you may have to change your devices based on how the polyp is behaving. The braided definitely, as I said, will help in difficult locations, but because of the thickness will cause slight more coagulation. Hence, always go with the endocut mode. So lifting agents, what do you lift with? Well, it's usually if the polyps are greater than 2 centimeters, I'll definitely use lifting agent. In fact, even greater than 15 millimeters. And proximal colon is definitely something, even if I'm doing a saline lift polypectomy, I'll use some form of lifting agent. And that's because of the thinness of the wall. This provides a submucosal cushion, and the fluid also decreases the likelihood of thermal injury to the serosal surface. So if you're going to make a concoction that's usually made out of normal or hypertonic saline, with or without a dye agent, such as methylene blue or indigo carmine, and with or without epinephrine. If you use epinephrine, it's usually diluted in various ratios. If I go with a saline solution, I personally use saline, normal saline, with indigo carmine, with 1:40,000 epinephrine dilution. So I want just that hemostasis, but I don't want the blanching that comes with a stronger solution. Hyaluronate can also be added, and that gives the viscosity for a more sustained lift. So these are concoctions, again, that may take time. If you're in the middle of a procedure, if you run out, the nurses or the assistants may have to re-prepare something, and you may not have the luxury of that. So this is an example of an EMR saline, and this is a lesion in the rectum. As you can see, it's a fairly large lesion that we're trying to assess with high definition white light, as well as with narrowband imaging. Now, on certain occasions, I will do an ultrasound. Again, endoscopic ultrasound is not as good for delineating between mucosal and submucosal involvement. This was more to make sure that there is no muscularis propria involvement. And as you can see, the muscular layer is pretty intact, and there's no local lymph node metastasis or any suspicious lymph nodes around there. I do not do EUS as a routine. It's only if there is any suspicion of invasiveness. After the EUS, again, I don't know if this is still going to have a submucosal involvement or not. The only way to tell is by trying to see if it lifts. So this is a saline mixed with methylene blue with epinephrine injection. As you can see, it lifted pretty fairly, at least comfortably enough to attempt an endoscopic mucosal resection. So this is a braided snare that I'm trying to get around the polyp. And obviously, it's too big to be removed en bloc. So this is going to be a piecemeal resection. I do apply this mechanical traction. So it's an electrocautery as well as this shaking, and that reduces the thermal energy because it brings an element of mechanical traction to the resection of these devices. When you use saline, it's important to note this step that you do need to re-inject. Saline does not last as long as the pre-mixed viscous agents. And in spite of adding epinephrine, as you can see, that does not guarantee that you will not have bleeding. And that blanching up top that you notice, that's because of the epinephrine in the solution. After resecting majority of the polyp, you need to make sure to prevent recurrence. I use a hot avulsion technique with a hot biopsy forceps, and then that entire lesion is closed shut with endoclips. So as you can see, what we started off with and what we ended up with, patients, a lot of time and the right kind of prep with the scope with the cap, a premixed solution. And the important point here is to make sure you keep lifting so as to avoid any damage or injury to the muscle layer. And as you saw, that was a clean submucosa without any injury to the muscularis propria layer. So on follow-up, this came back as a sessile tubulovillous adenoma without any high-grade dysplasia or invasive cancer, and the deep tissue edges were uninvolved. So like I said, endoscopic ultrasound does not guarantee the involvement of the depth of invasion. It's more for muscularis, so I do not do that as a routine, but here it did pay off. So that brings us to the lifting agents. As I said, with saline, the lift doesn't last as long, and you have to constantly keep relifting almost between each resections. So there are premixed agents, one of them being Everlift, and the lift, of course, is significantly longer than a saline solution. There is no prep or mixing needed, as it already comes pre-mixed with methylene blue in it to give you that blue effect of the staining of the submucosa. There is a darker color that also helps us with the margin delineation, as I'll show you in the subsequent video. It has cellulose based with hypertonicity, in order to give a longer lasting lift. There is a slow rate of absorption, so this reduces the need for repeat injections in between resections. It comes in two sizes. This is the unique feature. There are other solutions also available on the market that come as pre-mixed agents, but they're usually in 10 ml vials. However, Everlift comes in both 5 ml and 10 ml vials. So based on the size of the lesion, or if you start with 10 and you only need a little bit extra, there's definitely cost savings with that. So you don't have to open a whole nother 10 ml. The only downside is there is no epinephrine, and that's true for any of these lesions. But like I just showed you, that epinephrine does not guarantee hemostasis. It's what we do during the procedure to make sure that there is no intra or post-procedural bleeding. So this is an example of when to attempt resection versus not. As you can see, this is the lesion I showed you initially that was referred over. However, the initial biopsies only showed it to be a tubular villus adenoma. Hence, we tried to lift it. And as you can see, the involvement of this lesion is significant. So when you try to inject it, there is no lifting. And this should be a warning sign not to continue with endoscopic resection, as this is a deeper depth of involvement, and this would not be amenable to endoscopic resection. This patient did end up with a right hemicolectomy and did have invasive adenocarcinoma of the colon. In regards to device preps, it's important to have retrieval devices such as a retrieval net or a polyp trap if you're going to do a piecemeal resection and want to suction it through, and a tattoo agents to mark the polyp in case of follow-up surveillance to know where to look for. Sometimes if the resection is really good, it'll be hard even to find the scar. So it's important to tattoo it, but again, coming back to the original paradigm, make sure the tattoo is further away from the resection site. So closure or hemostatic devices, there are various endoclips, over-the-scope clips, as well as suturing systems available. And it's important to have a variety of all of these because you're not going to know upfront what we're going to need. You know, like I showed you in the previous video, I was able to close that with endoscopic hemoclips. Usually I'll try a wide jaw clip, such as 16 millimeter clip, which gives better approximation of the tissue edges. But again, that's tailored based on the size of the lesion resection. So this is an EMR with the Everlift premix solution. Again, another lesion in the rectum, but as you can see, it almost touches the dentate line. It doesn't touch it, but it almost gets there. There's hardly a couple of millimeters of space there. So after having watched it on high definition white light and narrowband imaging, this is a chromoscopy to better ascertain the edges of the lesion and make sure that the anal area is not involved. Followed by that, I used a 25 gauge injection lifting needle. And as you can see, it gives you that beautiful blue, not just for the lift, but also delineates the borders. So as you can see, now you know where the end of the lesion is. Followed by that, I use a braided stiff snare for piecemeal resection of this lesion in the rectum. The important part here is that the lift continues to stay in spite of repeated resections, so that reduces the need for re-injections and continues to maintain that safety. This is another part is the device change. So now I changed the snare because the snare I had initially, the braided snare, was not able to capture the lesion or the remnants. Underwater EMR is also important. It helps the snare to not slide. Sometimes with CO2 insufflation, it is so stiff that we're not able to remove it, and change in snare is important. Hot biopsy avulsion of the tissue edges to get rid of any of the remaining lesions and also to reduce the risk of recurrence. During the procedure, if there is any bleeding, make sure that this is controlled. So this is with the same hot avulsion, hot biopsy forceps, using a soft coag mode, all the bleeding vessels as well as the potential vessels in the resection site is cauterized. This significantly reduces the risk of post-procedural bleeding, especially if the patients are on anticoagulation. The resection site closure was able to be accomplished with a wide jaw 16 millimeter clip, and the patient was able to get this lesion resected without the need for surgery. As you could imagine, with a lesion this low, this would have been a major surgery, and we were able to successfully remove this lesion with negative margins. So once an adequate lift has been achieved, an EMR is usually performed if the lesion is 2 to 3 centimeters for unblocked resection. But if it's bigger than that, then it's going to require a piecemeal resection, as we just saw. The unblocked resection, the benefit is that it gives us a single piece of tissue similar to ESD, and we're able to assess the lateral as well as the deep margins for completeness of resection. However, with EMR, we are able to get the deeper edges, but not the lateral edges. So this is an example of an unblocked resection. Again, this is an appendiceal orifice polyp, which turned out to be a serrated adenoma. And after injecting it with Everlift, as you can see, the polyp kind of comes out of the appendiceal orifice. So initially, the plan was to assess the lesion to see if it lifts out. If not, a polyp like this would have required an endoscopic full thickness resection. However, when we inject it with this viscous agent, the polyp does evert out, and the agent, the injection, the Everlift agent, also gives us the edges to be able to tell how big of a lesion this is. So this polyp was about 25 millimeters in size after we were able to pop it out, and then using a large braided snare, we were able to remove this lesion unblock. The lesion site is closed with endoclips, and then the polyp is retrieved using a retrieval net. So here again, the Everlift or the premix mixing solution is able to help avoid a major surgery or a full thickness resection, and we were able to successfully endoscopically resect it in a single piece. So there are other assistive devices, such as this dilumen device or the Pathfinder overtube device. And what these devices help in is to stabilize the colon and be able to go in and out of the colon multiple times, especially if it's on the right side of the colon. Sometimes it's helpful even in the sigmoid to help straighten out the area that we're working on. And between the forward and the aft balloons, we're able to work in a controlled environment. The Pathfinder is a rigidizing overtube that helps, again, in a loopy colon to be able to get stability, especially for advanced endoscopic resections. So this is an EMR in the sigmoid colon. Again, the polyp was hiding behind the folds of the sigmoid, and the sigmoid loops kept dropping over it. So I chose to go with the overtube-assisted endoscopic mucosal resection. So the forward balloon is pushed out into the sigmoid, and that helped straighten out the fold, by which I was then able to find this large polyp over which the fold kept falling over. Now, the other important part here is to watch the tattoo. So this is part of the don'ts. So importantly, it was important to tattoo this because the referring doctor had found that it was hiding underneath the fold and was worried that I may not be able to find it, or maybe missed it. However, again, the size of it, I feel that it's something that would have shown itself with a careful exam. However, placing the tattoo is not the problem, it's where it's placed. As you can see up here at 12 to 1 o'clock, this tattoo was put immediately underneath the polyp. Now, although that did help find the polyp, however, it's not going to be helpful in the resection. So the overtube definitely helped open out the area. And after a careful exam, we were able to assess that this was a significantly large lesion, but something that we could try. But the tattoo here is what bothered me, because I wasn't sure how that area specifically was going to lift. So I tried to see how this resection is going to go, and as expected, as we inject the lifting agent, that area doesn't want to lift. So it's fixed and scarred. And again, this is not because it's an advanced polyp or if there is cancer in it, it's because the tattoo has caused fibrosis underneath the polyp, which has caused it to tack down. So there is ways around these things. You basically, if that doesn't work, you try to find an area that is relatively free of the tattoo. So on the other side, we try to see if we can get an adequate lift. So that's what we did. We were able to go on the 10, 11 o'clock. And as you can see here, without the tattoo being present, this area lifts fairly well. Now you can ride on the coattails of that. So basically, I go into the valley of the mountain. So when there is a lift, you want to inject into the valley, and that helped us lift the other side. So we did a piecemeal resection with the snare, and the remaining lesions were removed with the hot avulsion. And the overtube helps us go in and out multiple times without losing position, and the stability is there. And at the end of it, I was able to remove the entire polyp, but as you can see where that tattoo was, there is significant scarring and fibrosis, which is what was causing difficulty in lifting. So this remaining area was then closed up with endoclips. And this is the zipper fashion where one by one you start at the normal tissue edge and then it brings the edges closure. And again, this was an advanced adenoma without malignancy, and the patient did great. So cold snare is another way to go during an EMR. It minimizes the risk of delayed bleeding or perforation because it slides over, and the residual polyp rates are similar to a hot snare. So a piecemeal resection with a cold snare is also acceptable as long as the polyp size is within what could be removed. However, as you mentioned, it reduces the risk of delayed bleeding, but you can see bleeding immediately at the time because there is no cautery involved, especially in patients who have underlying anticoagulants. So this polyp looks easy, removable. There's no high-risk features about it. And after a cold snare resection, of course, there is bleeding. And this is the important part, is to make sure that this actively oozing site is taken care of and we achieve hemostasis at the same time. Again, this could be done with through the scope endoclips, which are able to achieve hemostasis and prevent an issue after the patient is discharged. So what about incomplete resections during the procedure or recurrence of polyp after on surveillance? Well, we could try to remove the remaining part of it with a cold snare. We could try a hot biopsy avulsion, which is the hot biopsy forceps, a snare tip coagulation to get the edges, using APC or argon plasma coagulation to burn off the edges of the remaining polyp, use an advanced tool called an endorotor resection, which is basically a scraping catheter that scrapes off the residual polyp, or if the polyp is scarred down, it may require a full thickness resection device. So an EFTR, which is an endoscopic full thickness resection, can be used for scarred polyps, polyps that extend into the appendix. So had that polyp I showed earlier not come out with the Everlift injection agent, then the backup plan was to do an EFTR on that. It requires special training, which is offered at few centers of excellence across the country. And there is still a risk of perforation and risk of appendicitis in spite of full thickness closure. So this is an example of after an EMR, at the edges, there is some remnant lesions, and APC of the edges has shown to reduce the risk of recurrence or residual polyp. This is a polyp inside of an FAP where there is already inflammation and scarring, and this is not something that's going to be amenable to endoscopic mucosal resection via the traditional techniques of lifting. So in this case, the polyp is injected with epinephrine, and then this resection device called an endorotor is used. And as you can see, it has a suction opening with a rotating scraper that basically avulses or cold avulses the adenomatous polyp out of the mucosa. Post resection at 3 months, as you can see, there was no recurrence and the patient did fine. In regards to endoscopic full thickness resection, again, this is an appendiceal orifice polyp that did not evert out. And using an FTRD device, this polyp is pulled in with a grasping forceps into the cap. And there is a special settings for it. And then the clip is deployed, followed by resection. And as you can see, this is a full thickness resection, which could be seen on the receptor tissue as well as the resection site. Here, the benefit is that you're closing the defect before even causing the defect. So the full thickness clip goes on first, followed by endoscopic resection with the snare. So you've already achieved closure prior to removing the polyp. Again, it does have its benefits in polyps that are not amenable to complete mucosal resection. Anticoagulation, so EMR and ESD are high-risk procedures, and we need to work with our colleagues from cardiology, neurology, as well as primary care to discuss the risk versus benefit. I almost always continue their aspirin therapy, and I tailor the holding of their antiplatelet as well as anticoagulant agents based on their therapeutic need. However, there is a higher risk of delayed bleeding when anticoagulation is resumed early. Bleeding, of course, is one of the known complications, and there could be delayed bleeding, and that could be based on the size, location, as well as the type of anticoagulation being used. Pure cut versus pure coagulation versus endocut needs to be taken into consideration. Pure cut, of course, has a cleaner and quicker resection, but it does cause bleeding. Coagulation, on the other hand, causes less bleeding but more charring. So the in-between is the endocut, which is a blended current, which is a mix of both cut and coagulation. Endoscopic hemostasis is always successful. Like I showed earlier, I always am preemptive in regards to either using the hot biopsy or a coag grasper or endoclips for closure as well as for hemostasis. Endoscopic suturing has also been used, especially for large defect size closures that may not be amenable to endoclip closure. I usually clip if the patient is going back on the anticoagulation, if the patient comes from a long distance and comes from a rural area being referred 2-3 years out, or 2-3 hours out, I mean, and especially on the right side of the colon, again, being thinner area, I try to clip it. To get to that area is always harder. If it's a rectosigmoid polyp, I know even if there is bleeding, I'll be able to get to it relatively quickly. The right side of the colon is going to require an extensive prep and may not be easily accessible. So this is the studies of the effectiveness of the hemostatic clip. And as you can see, for EMR, from large defect closures of greater than 20 millimeters, delayed bleeding without clipping was in the range of 9 to 12%, which all significantly went down with clipping. The data I know is out there. There is some trials that show that there is no effect no in the outcomes of these patients, but again, it's a case-by-case thing. So watch for the target sign. I always examine the specimen that I take out. And if you see the target sign, recognize that early, because if you see the serosa here in the lesion, that means there is a piece of serosa missing inside the patient. So definitely intervene early during the procedure. You can use an over-the-scope clip, regular endoclips, or endoscopic suturing, depending on the size of the perforation and the location of the perforation. So this is showing in the rectum. As you can see here, this patient also had a tattoo placed, and sometimes that plays into the risk of perforation as it causes significant scarring. And after doing an EMR, you realize that that scarring then that led to a full thickness resection. So because it's in the rectum and the size is fairly small, I felt that this was easily achievable with a zipper closure with through the scope endoclips, and the patient did fine. But this is the benefit of using CO2 insufflation, so we do not cause a pneumoperitoneum, and immediate recognition and closure prevents significant morbidity and even mortality down the road. This is perforation closure on the right side. So this was in the cecum in a patient who already had a prior EMR and there was a residual polyp. And upon removing that, there was a full thickness defect left after a snare EMR. So I was able to drive there using an over-the-scope clip. And as you can see in the middle, that's peritoneal fat. So you can see a full thickness defect in the cecum at the site of the EMR. The important part is not just the CO2 insufflation, but I also try to do an underwater progression. So this way I have less leakage of gas. And then by suction, it almost creates an omental patch where the fat is pulled in and the over-the-scope clip is deployed. And you can see that entire defect is within the over-the-scope clip. After I've completed that, I do some insufflation to check and make sure that the entire defect is in fact inside. And then as you can see on the resected specimen, there's definitely a serosal fat to that. So this patient did end up with a negative margins and we were able to remove the residual polyp, but identification of the defect is important and closure at the same time is of importance as well. Post-polypectomy syndromes, it's a local peritoneal irritation because of transmural thermal damage, and this is why knowing the Cautery settings is important. It can happen in 0.5 to up to 1.2% of polypectomies and EMR. It can present 1 to 5 days after the colonoscopy. So it's not something that may happen immediately post-op, but it's definitely something to let the patient know, especially if it's a large piecemeal resection and I've done a lot of hot snare removals. I know that I've used a lot of thermal energy, and you want to be cautious of that. Patient may complain of fever, localized abdominal pain, and leukocytosis, as well as peritoneal signs. Usually free air is not seen, as this is more of a serosal inflammation or irritation. And the treatment is usually NPO, antibiotics, and follow-up to make sure that the patient recovers uneventfully, and usually that is the case. So surveillance, after I do a large PCMR, especially of an end lesion greater than 20 millimeters, I call the patient back in 6 months, and then 1 year, and then 3 years thereafter, depending, of course, on the pathology and the morphology of the original polyp. This gives me the opportunity to catch any residual or recurrent polyp early on before it has a chance of turning into an advanced adenoma or malignancy. So recurrence or residual adenoma at the first surveillance colonoscopy could be up to 10 to 30%, especially after a piecemeal EMR, and hence the need for surveillance. And like I said, it is usually handled endoscopically. And we could do this either with a full thickness resection or an endorotor resection. The recurrence could be removed either with a hot biopsy avulsion, repeating an EMR as long as there is adequate lifting, either by doing an EST, which may be challenging given the scarring or the fibrosis from the initial resection, doing endoscopic full thickness resection, or again using the endorotor. So this is a case where I had done an EMR, and then on the follow-up, I found that there was probably a little bit of nodularity left. And here is the scar with healthy tissue at the site of the prior EMR. However, when you turn the NBI on, I realized that it probably is a little more extensive than I thought initially. And on injection, of course, it doesn't lift as well because this is the area of a large laterally spreading 45 millimeter polyp that was removed. So there is significant scarring. So this is the resection device. It has that suction cup at the bottom. You inject it with epinephrine because it's literally just scraping. It's a cold avulsion of that lesion. And I'm able to scrape off the residual polyp. And as you can see, there is significant fibrosis underneath there. So those scar tissue you're watching is all the fibrosis that was pulled out. And this was actually in 2 sites. So at the same time, I was able to remove that entire area of residual polyp at both the sites, at the proximal and the distal extent of the original polyp. Because it's a cold avulsion, again, there will be some oozing or bleeding, and that needs to be addressed at the time of the resection itself. And like I said, on the right side of the colon, I do close my defects so as to reduce the risk of delayed bleeding in these patients. So when to refer to surgery? So not just because we can do endoscopic resection doesn't mean we never need surgery. If patients have poorly differentiated cancer, if there's lymphovascular invasion, if there is a risk of nodal metastasis based on their resection, if there is deep submucosal invasion, or if we're unclear, or if there is positive margins, especially if the path comes back as an adenocarcinoma, then definitely a surgical referral is warranted. This is where a collaborative effort is important. So we have a multidisciplinary tumor board. Irrespective of the margins, I always discuss my endoscopic resection at the tumor board to get an opinion from our pathologist who reviews the path, as well as my colorectal surgical and oncology colleagues. And if everybody's on board, then either we continue with endoscopic surveillance versus see the patient to offer a surgical resection if the endoscopic resection was not complete. So there are definitely lesions that are beyond the scope of endoscopic resection who may need surgery. So virtually all non-invasive polyps at today's day and age could be resected endoscopically that in the past would have gone to surgery. Surgeries now are reserved for invasive cancer. Saline premix polypectomy versus EMR versus EST or surgery would be based on the predicted or proven invasiveness, and it has to be tailored on a case by case, and every lesion is different, every patient is different. Do not attempt resection if you don't think we can complete it, and definitely tattoo away from the lesion. So if we feel that this is not removable, you need to tattoo it for the surgeon to know what area of the colon needs to be removed. EMR and EST definitely is a specific skill set. that does require advanced training, sometimes not so much in removing the lesion, but managing the complications. If something does arise at the same time, if you're able to fix it, it reduces significant morbidity. It should be done at tertiary referral centers who have the other support systems in place in case if there is need for surgical intervention or interventional radiology guided intervention. Multidisciplinary management, like I said, is critical to discuss this with our other specialists, and referral to a center who have those resources in play definitely leads to a safer outcome for the patient. And at the end, I'll say just because we can doesn't mean always that we should. It's what the patient needs and what the patient deserves is what we should entail. This is the indication contraindication on the Everlift submucosal lifting agent, as well as the Spot X endoscopic tattoo marker. So I'll take any questions. And again, thank you for spending the evening with us and going over some of the tips and tricks that I use. I did not go into ESD. That's a whole other topic for discussion, but these are what I do for endoscopic mucosal resection at least.
Well, thank you, Dr. Khara, for this informative presentation. As you just mentioned, we're going to move into the Q&A portion. And so for any of our attendees, if you haven't already done so, please submit your questions and comments using the chat box at the bottom of your screen. But it does look like we have already gotten some questions in. So first question that we have is, how important is a tattoo in a case where the lesion is easily identifiable?
So again, it's not. So as I mentioned earlier, if the lesion is easily identifiable based on the size of it or the location of it, if it's in the rectum, rectosigmoid, or in the cecum, then definitely tattoo is not important. If it's anywhere in between, or if it's in a hidden position, if it's around the flexure, sometimes tattoo, these polyps could hide at the hepatic or the splenic flexures. The tattoos definitely may, bring it out. The other important part of tattooing is, again, where we cannot remove the lesion and we want to refer the patient for surgery, it definitely helps our surgical colleagues to assess the proximal and the distant extent. In that case, I actually tattoo on both sides, on the oral as well as the aboral side, so the surgical colleagues know what the extent of the lesion is.
Our next question is, do you close every defect anywhere in the colon?
Not necessarily. It is tailor-made. I don't close every single defect if I don't think that the lesion is high risk. If it's in the rectosigmoid area, where even if there is a bleeding later, I can probably get to it fairly easily. If it's deep enough where I have any suspicion or doubt that this could lead to a post-procedural complication, then I do close it. On the right side of the colon, obviously I do close it. If the patients are going to go back on anticoagulant medications, I do close it. All those reduce the risk of delayed complications, including bleeding and perforation.
The next question is, would you recommend MRI to assess the depth of a large polyp?
No, not necessarily, unless I think that if it's a malignancy, I do. MRI, again, is not as sensitive in assessing mucosal versus submucosal involvement. So if I feel endoscopic patterns appear that this is a non-advanced adenoma or an advanced adenoma limited to the mucosa or SM1, then I'll try an endoscopic resection. If it's not curative, at least it's diagnostic in finding the pathology of the polyp. But MRI would not lead that. If, on the other hand, we do find it's a carcinoma, then yes, then the patient needs a more robust staging. If it's a colonic lesion, then of course a staging CT, chest, abdomen, and pelvis is helpful. If it's a anorectal lesion, then a pelvic MRI is helpful in staging.
The next is, do you use any specific diet or medicines, such as diarrheal agents, to keep the clips in place for a longer time in a sigmoid or the rectum?
Now that's a really good question. Yes, so if the patient has issues with constipation, or you want to avoid the patients from bearing down, I don't do diarrheal agents. I just have the patients on stool softeners. So I'll tell them, at least for the next 3 to 5 days, make sure that they're on a stool softener, and I'll want them to watch out for the signs of either a delayed bleeding or perforation.
So at what interval do you surveillance after avulsion of a residual polyp post-EMR?
So usually along the same lines, around at the 6-month mark. Again, it depends on the pathology of the polyp. If it's an invasive polyp, then it could be sooner. If it's a large area that I have removed, I again want to stay on top of it, and I may call the patient sooner, within 3 to 6 months. But usually the 6-month mark is my go-to standard for most patients.
Another is tattoos tend to spread even when only minute amounts are injected. Any techniques for preventing this?
No, this is a great question and definitely something that we all struggle with. As you know, when we inject, we can't control where it's going. So what I do is I'll start with saline. So initially, I'll inject a little bit of saline up front so as not to directly start with the tattoo, and I'll see how that's spreading. And then I'll take the tattoo into that saline marker to just darken the color. Again, starting a little bit further away definitely helps with that. But it leads into the same thing. If we had tattoo markers that didn't spread as much or they were slightly more viscous, I think that would be very helpful in advanced endoscopy practices.
Another one is, do you consider cold snare EMR for larger polyps over 15 to 20 millimeters, especially sessile serrated lesions, or really what is your cutoff for a cold snare?
So if I do want to get, that's a nice question. I have done that. I'll do a piecemeal cold snare resections. I definitely have done that. If I want to just go with a cold snare, it's usually underneath of 15 millimeters. If it's something that's going to require injection and extensive removal, again, if the patient is on anticoagulant, then I'll always go to a hot snare. But cold snare EMRs I do undertake. Usually, if it's greater than 20, I try to go to a hot snare or a electrocautery enhanced resection.
Thank you. How do you approach recurrent adenoma at ICV?
So that's a tricky one. The IC valve is definitely a tricky location. So, and I did have a video clip, I didn't put that in here, but I usually try to go into the terminal ileum. So as long as the polyp is not growing into the valve, I think it's fair game for endoscopic resection. I will usually use a pediatric or a slim colonoscope, so to be able to retroflex in the cecum and make sure that the underside of the valve is not involved. The other thing you have to be careful is there is a lot of submucosal fat tissue. So you have to be careful when you inject because it could give the false appearance of a peritoneal fat. So the IC valve, again, using a PCF scope, using retroflexion, going into the terminal ileum to assess the depth of the involvement. And if you feel it's growing in, unfortunately, the patient may need just a partial ileocystectomy rather than endoscopic resection. But if it's on the valve, I've definitely done extensive ICV resections as well.
Another one is, when do you decide to attempt colonoscopy removal of a large polyp that is benign on initial biopsy or refer to surgical resection?
So again, that's a great question. It all comes down to the morphology of the polyp. If it looks like something that I will be able to remove, so based on their pit pattern, on the Paris classifications, on the visible depth of invasion, on the lift sign. So if you lift something with Everlift or with a saline mixed solution and it lifts well, then I'll definitely try to remove the lesion. I do take on the more challenging ones, so I'm comfortable with it. But again, like I said, if it's not something that you feel you're going to be able to finish, definitely don't start that. Either refer to an advanced endoscopy or a tertiary center or to surgery if that's what you have at your disposal.
And then we do have one more question that just came in to wrap up.
Sure.
Do you recommend biopsy confirmation of a large polyp that demands piecemeal resection?
No, absolutely. No, that's a great question, Mohammed. I think I do not. I do not need biopsy confirmation because visibly, if it looks like an adenomatous polyp, it probably is an adenomatous polyp. Even if it's not, what else is it going to be? You still got to remove it, right? It's not going to be a large hyperplastic polyp that's spreading. That's usually a serrated adenoma. So biopsy is not required because the problem is the biopsy will cause scarring. So don't try to do a hot snare. Don't try to do a cold snare. Don't try to biopsy. And in fact, don't try to tattoo it if it's within an easily accessible or a known location. I would say leave it alone. And that's what most of my colleagues will do. And that's where that photo documentation comes into play. Get good documentation of how it looks, how big it is, what is the white light and the NBI features, because then that helps me plan the resection better. But no, to answer the question in short, no, there is no need for a biopsy confirmation.
Wonderful. Well, thank you so much for all your responses to our questions that we had today. This will conclude today's presentation and our Q&A. I want to thank you again, Dr. Khara, and everyone enjoy your evening.